Thank you so much for joining us today, Natalie.
I'm excited to be here.
Yeah, I'm excited to see where the conversations are going to go. I mean, you've had so much experience and so much um, change and transformation. You've helped so many families. So I look forward to unpacking what that means for our caregivers today.
Awesome.
Before we get started, though, we have a Patreon where members of the village, which is what we call our Patreon supporters, are able to ask our guest one question. Here's a question that they gave for you today. There is so much information available right now to caregivers, specifically in the dementia space. How do you suggest that caregivers know what advice they need to trust?
Mm, that's a great question. And I think that it would be extremely overwhelming if somebody tried to consume all the information out there. It's impossible. And we don't need to know all the information. But when it comes to, okay, how do I think trust is a big one, but also who do I resonate with? Like everybody kind of has a little bit of a different teaching style. Somebody might be more animated and quick in their speech. Somebody else might be a little bit more calming. So I think that's something that is okay to consider when you're trying to figure out where do I want to get information. When it comes to trust, though, I do think in this day and age where there's so much on social media and we're in a world of influencers and many people who have wonderful personal experiences caregiving can now amass a huge following, I think it's important to consider what kind of credentials or experience somebody has because one person's personal experience doesn't necessarily mean they are an expert at maybe a wide variety of people's experience. So it just really depends what you're looking for. And don't ever stop going to your healthcare providers and actual clinicians, like the person who is seeing your loved one with dementia and assessing them and evaluating them. We have to continue to keep them in the loop, even though a lot of times what we see on our screens sounds a lot more interesting. Um, we live in a world where a lot of people, in order to get clicks and views and watch time, will say and do things knowing what will get the clicks and views and watch time. And so it's just a matter of what are their credentials? What are their degrees? Does their teaching style resonate with you? And before really doing anything significant, check with your loved ones, actual care providers. I know that's not like a super exciting answer, but I'd just be a little bit, you know, pause a little bit if you're following somebody who's just had the experience of personal caregiving. Extremely powerful, extremely wonderful. It's a nice perspective to have, but we might be missing out on some important information.
Yeah, I think it gets complicated though, I think for families because there you brought up credentials and credentials are a very valid one because there's so many different credentials out there. And it's the subjectivity of how do I evaluate what credential is important. So, I mean, you're a geropsychologist. There's geriatricians, there's neurologists, whether it's nurse practitioners, so registered social workers. They all navigate this space differently. So, how would you recommend an
Yes.
individual navigate the complexity of credentials in the space then?
Yes, that's a fantastic question. So, all of those credentials you mentioned are extremely important. And when we're talking about dementia care, the best type of dementia care is going to come from multiple different angles and perspectives. So, I think one important distinction is there are people who maybe have certificates in training that anybody can go get. And maybe it's not quite as rigorous, but it's a beautiful way to expand their learning. And then we actually have credentials like healthcare credentials where somebody is licensed to provide some sort of care. And what I would, first of all, I would say a social worker is probably a wonderful addition and help to anybody caring for somebody with dementia because they're often uh, somebody who is aware of the services and resources that are available in that community. So that's a great resource to have. Obviously, you're going to have some sort of primary care provider, whether it's an MD, a DO, an NP, like the person doing the actual medical health care. But beyond that, um, there are so many disciplines that I think don't get talked about enough that could also be helpful. Not that everybody needs all of these disciplines, but that's where like having a conversation, most people have a primary care provider. Having a conversation with that primary care provider and saying, these are my specific struggles. Number one, my loved one has a hard time communicating. Number two, I am so overwhelmed and frustrated. I don't know how much I can keep going. Like literally state your personal experience and what you're needing help with, and then ask that PCP, like, what sort of help can you provide? Ideally, that's a perfect place for a social worker as well because they're aware of the bigger picture. But great dementia care often involves more than a PCP and a neurologist. Because if somebody is coming to me and saying, "Hey, I'm really having a hard time communicating with my loved one, and it gets frustrating. They're trying to say something, they can't get it out. I don't know what they're trying to say. We're leading in arguments." Well, right away, I'm thinking, well, have you talked to a speech therapist? Has anybody done a speech therapy evaluation? Or if somebody is having a hard time moving around the house and maneuvering, I'm like, okay, well, have we talked to an occupational therapist? That's a weird word, but occupational therapist is all about managing their independence in their current living environment. We may have tools and like gadgets that can help keep them independent. If the caregiver is really frustrated and overwhelmed and is like, I don't even know how much longer I could go. Well, have you talked to a psychologist? Right? So I 100% resonate with this question in terms of it is so overwhelming. But what I will say is that you, as a caregiver, don't have to come up with all the answers. If you have a great relationship with the PCP, let them know specifically, this is what I'm experiencing. What other resources are there? And if you have a PCP where maybe it's just like, "Well, this is it," then try to seek out a social worker would be probably my first start. And they have a great understanding of here are all the different resources and disciplines that can actually help.
Wow. Thank you. That definitely cleared that up, and I think it made it very evident that the first step is to, figure out and talk to your primary care providers and say, this is what I need. This is what I'm seeing. You can then have them help expand that and bring in the people necessary to support in the way you need.
Right. Like the caregiver might not be able to say off the top of their head, I need a speech therapist or I need an occupational therapist. There's so much misunderstanding around what they can do anyway. But if they share their exact struggles and what they're frustrated with, well, that will, the person they're talking to will hopefully understand what disciplines would most help in those situations.
So, how did you get started? What was your life like before you got into this space?
So before I started Careblazers or before I started in
Before
the
you,
dementia
I
care?
guess when growing up, did you know you wanted to be a geropsychologist?
No, I did not even know what a geropsychologist was until I was about to get my doctorate degree. Now, this is the thing. So, most people assume a fancy degree means they've got training in geriatrics. But I'm here to tell you there's very little attention in the field of geriatrics as you're going to get your basic degree. So, an MD, a DO, a PhD, a PsyD, whatever it is a drop in the bucket what you learn to get your degree. Getting your initial graduate level degree, advanced degree, that is all about more of a generalist. You're just generally learning about me as a psychologist. I'm generally learning about the brain, behavior, how it connects, all the different, I'm getting exposed to different maybe populations, but it is not a specialty in geriatrics. In order for most people across disciplines, the geriatric specialization literally is something you raise your hand for and say, I want to go further in this area. And what that's going to require is more years of training, more money that you're going to spend to get that training, and people going on to get, we call it board certification to get board certified. Um, but I think it's important that everybody knows the traditional training, it's not like geriatrics is a huge focus. You're just trying to get all the basic foundational training you can um, as you get that degree.
So when you finished your Psych D, did you go on and do additional trainings in that specialty?
Yes. I did. I went and I got an APA approved fellowship in geropsychology, which was like one of the very few that even existed in the entire country. And that training for the full year is 100% only geriatric focused. And then after that, and after working in the field, specifically in geriatrics, you can then apply for board certification in geropsychology, which is basically, you go in front of a board, you submit a lot of stuff ahead of time. You have to prove your education, your training. They question you, they give you scenarios, they, do test your knowledge and things like that. And you have to keep that up. So in addition to like the basic, clinical psychology license, there's also the board certification, ongoing proof that you are still a specialist in your field. So, yeah, I sought out specific geriatric training.
Okay, so you are I would say registered psychologist is what we have up here as the title, as well as board certified then?
I am a clinical psychologist, so that's what we call it. That's what my degree is in, and that's licensed. And in my state, in order to call yourself a psychologist, it means you have a doctorate degree in psychology, and mine's clinical psychology. And then I went and got a fellowship in geropsychology, and then I got board certified in geropsychology. So now I am a board certified geropsychologist, but the foundation underneath all that is clinical psychology.
So what led you into geriatrics?
So the first like drop that really opened my eyes is I'm in what we call a clinical internship. So it's basically the last year of clinical training before you get your degree. It doesn't mean you're licensed, right? But you literally would get your doctorate degree. And in that training, it was a forensic setting, which it was a state hospital where I helped people who were convicted, usually of a murder, but they were determined to be, in our state, we call it insane, guilty except insane, GEI. And what I noticed, we did lots of group therapy with the people in that state hospital. And there was one gentleman that just stood out to me. He never spoke. Nobody ever talked to him. He seemed to be a loner. And I was just so curious what was going on with him. And he was noticeably much older than everybody else in that group. And I would ask, kind of the group leader, what's going on with this gentleman? Oh, he's just quiet. He doesn't really talk much. And I sought him out one day to go talk to him. He is hard of hearing. He cannot hear. He doesn't even know what was going on in the group. So we were just treating him like all of the other inmates who were decades younger. And like that was the first aha of older adults likely have different needs and considerations that we need to be assessing for if we're going to do like our due diligence. So that's the first thing that opened my eye. And then I'm like reflecting back on all of the years of training I did up until this like last clinical experience. And I'm realizing I don't have much education about this population at all. And then I start researching and I'm like, hardly anybody has education on this population. It seems to be the attention we give to older adults is very minuscule. So when it came time to do a fellowship, like after I got my degree, I just started searching for fellowships and came across one in geropsychology, which was like literally less than a handful in the entire country. And I decided to take it, even though that wasn't anything that was like, it was just this one experience that just opened my eyes that I have a huge gap. I have a huge gap in my knowledge and training, and I want to go learn more about it. So I took that fellowship and I never looked back since then. I realized like this is where I want to be. There's so much that needs to be done. And even working in the hospital system, you see how many other people don't have the knowledge and information about working with older adults. So I felt like I wanted to work with this population. There was lots of benefit to me, like I got a lot out of it, but also there was this huge need to educate other colleagues that are around me in terms of how we need to be approaching older adults and that, you know, there are different considerations we maybe aren't considering when we're seeing a 20 or 30-year-old.
So if you were studying geriatrics, there's lots of things that you could have specialized in as a geriatric psychologist. Um, why dementia specifically?
So a lot of the older adults I was seeing at the time, I was working at the VA hospital. A lot of them had cognitive impairment. And so, in that very first year, one of my first experiences was actually doing the assessment and the testing to figure out if somebody did have dementia. And so that was just a whole fascinating piece. And I saw how much it could either tear families apart or bring them together in terms of understanding what was going on, if what they were doing was on purpose, if they had any control over it. Um, I saw the importance of if the healthcare provider didn't understand there was something going on, that we could just assume they're not wanting to take their medication or, it's horrible, but we would see, oh, they're resistant or treatment resistant or non-compliant. And, it didn't sit right with me. This was something that I felt like on the family level, we needed to do a better job of letting them know what was going on and supporting the family for what was to come in the years ahead. But also on the healthcare system level, we, ha- you know, a quick 20-minute appointment to check in on something, we just assume the person in front of us is going to be able to understand, remember it, recall, follow the recommendations. Just felt like this was not great healthcare long term. So dementia was a condition that I felt I wanted to give more attention to. Um, on both aspects, the education piece for the hospital, but also one-on-one with the family and the person with dementia. Um, it just didn't seem like there was a lot there. And the way that the system was set up wasn't able to provide the family, I thought, with the support needed. So, for example, let's say we discover somebody actually does have some type of dementia. Well, now what are we going to do? Ask the family member to come in so we can support them? Like, how much of a strain and hardship is that on them? Can they bring their loved one with them? Do they need to find somebody to care for their loved one while they come? Is it enough to just give them, a handout with a couple of numbers to call and tell them to attend a support group? Well, how can they get to that support group? So it just felt like a place where we had so much work to do. And I, I wanted to take the challenge.
Did you have any exposure to dementia growing up?
Not growing up. No, not at all, that I know of or can recall. But over the last years of both of my parents' life, my mom and my dad, there's very clear cognitive impairment. But that was well after I ever entered this field.
So shifting a little bit, you mentioned that you spent quite a bit of time with Veterans Affairs and supporting those individuals, and I mean to the fact that your program is still being supported by the VA now. Have you seen any correlation between uh, TBI and dementia?
Yeah, so traumatic brain injury can be a contributor to dementia. There's literally a type of dementia that would be called dementia due to traumatic brain injury. So that is absolutely something that's been studied. It's a source of dementia. Um, you know, yeah.
Do you find systematically that the supports are working right now for those individuals in service or in other industries that um, would experience this that can get the support specifically because of a TBI?
So if I understand your question, I do think, I will say, I think the VA provides amazing care for older adults with dementia. They are one of the few places where it's comprehensive. They actually know all the disciplines that are around. They know when I worked at a geriatric assessment clinic, we called it Geriatric Evaluation and Management Clinic. We literally had every person who came in was seen by me, geropsychologist, speech therapist, occupational therapist, physical therapist, an MD, or like PCP geriatrician, a social worker, and occasionally, depending on the person, it would be chaplain and psychiatrist as well. Every single one. besides a chaplain psychiatrist, which was maybe not every single one, all those other disciplines I just mentioned got evaluated by every single one of those. So I will say, and the Veterans Affairs is TBI is something that they are well aware of with, blast injuries and things like that. So I think that they do a pretty good job at being able to identify it, offer treatment and needs. I think the big difference there that's a little bit hard and where I see maybe the family members struggling is that a lot of times they're much younger, right? Because of the traumatic brain injury has happened at an earlier age. Their dementia oftentimes is also an earlier age. So, like, I can recall working with some gentlemen who are, maybe in their 40s or 50s. And so the challenge is a lot of the supports we have are really the majority of people going there are going to be in their 65 and older, 70s, 80s. And so a lot of times the younger men who have dementia due to traumatic brain injury feel out of place, maybe in those kinds of support systems, or the people are much, much older. But also the caregiver has very different needs as well. They're probably might be raising like very young kids. They might still be in the prime of their working lives. And they feel like the other like caregivers around them are much different than they are too. So I think that's a unique aspect of, for sure early onset dementia, but a lot of times people with the traumatic brain injury type tend to be younger as well.
How do you suggest a caregiver support someone with early onset? Since you brought it up, and it's if these individual TBI likely have a younger age developing these symptoms, right? And they're starting to be, diagnosed this. And but the supports are reflective of older adults. How do they navigate it? So the reason I ask this is I know an individual who their mom ended up with early onset dementia and she was in her early 50s. And she actually took her life because she said, I'm not old like these individuals that have it. I don't want to go to these groups. I don't want to be these supports. I don't want to be viewed as one of these people. I'm much younger, and she ended up taking her life in her early
Yeah.
50s.
Yeah. That is so sad. And, I talk to lots of caregivers, and some of them are, in some ways, I would say, like, turned off by some of the support groups to hear, the experience is so different, and they feel like maybe they're alone. They feel like nobody gets what I'm going through. So I think we have to do better as like a system, right? On a system level, we have to be able to acknowledge early onset dementia is going to require maybe a different level of support for the person with the diagnosis, but also for the family caregiver. We have to provide more and recognize they might not fit in so well with the people in moderate to severe stage Alzheimer's disease, where most people are going to be, much, much older. Um, I also think, this is where, friends, family checking in, that's going to be really helpful too. It might not look like the traditional like dementia care and support, but this is I don't have a good answer. This is a really big issue and concern because another thing that I ran into when working with younger people with dementia is that they didn't even qualify for some of the services. For instance, like an adult day healthcare program or some sort of community resource we have, it was pretty much geared toward 65 plus, maybe 55 plus. And so some of these younger people were not even technically eligible for some of these resources. It's a big concern.
So how do we fix it?
Yeah, I don't know. I this is probably something that lawmakers, policymakers, people have to recognize is like important, that we need to come up with things or we need to change eligibility and requirements for certain areas. Um, I don't know. Like I can tell you personally, like I have a program and we do support rooms weekly. And one of the things I notice is that people who have young are caring for somebody with younger onset dementia or are more in the earlier stages, they tended to get pretty freaked out and scared at listening to what our members in more moderate and severe stages were saying. So, like on a personal level, we created a group. We created a separate group for early onset slash mild stage of dementia caregiving so that if they wanted to go to those other ones, they still could. But we created a group where we're going to all be in a similar situation here. So that's just like me on a personal level, but that's nothing for what we need to do on a systemic level.
And what's interesting, Natalie, is so I'm in Canada and we have, publicly funded healthcare and so forth, but I still don't see this a resolution to this here where we should objectively, if fully funded healthcare, have supports, but we
Yeah,
don't. So we're in a similar position too. I know other countries like Australia and England have a similar position as well. And that's an ignored demographic of dementia,
yeah,
an already stigmatized condition.
right. Yeah. And I think another specific hardship in this group is because the person is younger, or even if they just have more mild version and tend to be older, they don't look like what everybody thinks the person is supposed to look like. So sometimes even the support and care and check-ins you would get from the people around you don't happen as much because it's like he's just 55, or he was able to remember me, or we had a decent conversation. And I think there's a lot of misunderstanding or a lot of emphasis on an older person who can't have a conversation, who can't remember who the caregiver is, who's probably in a wheelchair. Like that's what we envision. And we're, a lot of amazing people are out there trying to share that that's actually not how it always looks. In most cases, like it starts much more mild. And you don't even have to have memory impairment to have dementia. So I think it's more of like a collective education and awareness campaign of like what it actually looks like and how it impacts the family so that maybe more people can start caring about it.
Looking in your clinical training, were there anything that you were taught or even implied but not explicitly stated about dementia care that you realize now being board certified, um, that was wrong or exaggerated?
Um, there's nothing major coming to mind. I will say there's like little, maybe offhanded comments that now looking back, I would say that's not actually accurate. And I think it comes down to this. We want uh, things to be in clear boxes. We want things to be very um, clear, easy to follow. There's these stages, they happen here. And what I know to be true is that it's not clean boxes. It's not so clear cut. So, for instance, the example coming to mind is I remember getting supervised by somebody and they said, hey, like, we don't want to use baby talk when we're talking to somebody with dementia. And what they were referring to is the baby talk of like, oh, hi, how are you doing, Andrew? That shirt looks so good on you. It's that voice, that like baby talk kind of voice. And in the moment, I'm like, oh, yeah, that makes sense. They're like, it's demeaning. It's, not a great thing. I'm like, absolutely. And then what I discovered is like some people, like you could observe their family members or people interacting with them. Some people lit up at that type of communication. Some people actually um, liked when people were communicating in that way. So we certainly wouldn't start off any conversation like that. We wouldn't assume to talk like that. But it was an awareness like of when are not all dementia people are the same, which means they're not all going to respond to the same approach, which means we have to be looking at the individual first and not just their diagnosis. So that's like one example that comes to mind. I'm not sure I'm recalling another example off the top of my head. I mean, I wouldn't say things that I've been taught, but things that I hear and observe. For instance, some facilities might say, hey, your loved one's, going to move into our facility. Please stay away for a couple of weeks to help them adjust. Like in some circles, that's like a standard thing. Well, that's actually not great? Are we to say that every single person with dementia, their family should literally stay away for the 2 weeks that they're there to help them adjust? No, some people are going to be okay with family checking in. So I think, if anything, what I would say, these blanket shoulds and shouldn'ts need to be more adapted to the individual, and not just assumed everybody's going to respond the right way. Because then we have family members trying to follow these rules that might not even be best for their loved one.
That's totally fair. What is one thing that you think caregivers um, should understand early on as they start this journey before, it gets overly overwhelming, complicated, um, and difficult to go through?
Oh, I could do a whole we could talk for a full hour on this. Number one, I would say, especially in the early stages, um, be open to accepting help and asking for help, even though you don't necessarily need it at this stage. So a lot of times, people will say, well, I don't need help. It's like, okay, that's great, but would you like it? Would it be nice? Some of us without any loved ones with dementia might love somebody to drop us off dinner one day, or to mow our lawn for us, or to take out the trash, or get groceries, or help clean the home. Like, s- uh, don't think you have to need help in order to accept it. This is going to be, for many people, a long journey where more and more help is going to be needed. Get get uncomfortable early on accepting that help and asking for that help. And it also allows your loved one with dementia to get used to other people being around, or other things happening, or um, accept help early on. That's what I will say. And you don't have to need it to to want it, and wanting it is enough. Um, don't put, I would say, another thing is, don't put all of your interest and desires on hold until caregiving is over. I know it's going to be hard, and it won't look the same, and you're not going to have the time, luxury that maybe you had before, but don't put yourself on the back burner, your hobbies, your relationships, your friendships. Don't put them on pause until it's over, because who you are at the end of it, like, you might find yourself extremely isolated, in poor health, not really enjoying much at all. And the big message here is, there's no amount of joy you can withhold from yourself that's going to reverse your loved one's disease. There's no amount of you just sacrificing and running yourself into the ground that's even going to make your loved one better. Withholding joy from yourself doesn't give joy to your loved one. So, um, realistically, consider, how might I still keep some of my desires alive? Um, yeah. And then, if I had to say maybe just two other quick things, and this might be hard to hear, but um, there's no amount of caregiving. You could follow all the advice, follow all the recommendations from their doctor, do everything as perfectly as possible. Your loved one's still going to decline. So you cannot attach how well you are doing to how well they are doing. The disease is going to happen and progress. So just making sure you're not putting that pressure on yourself. Um, and then it's going to be hard. It's going to hurt. It's going to be painful. It's going to be heartbreaking. Uh, there's nothing that's going to ever take that away. So there's things we can do to maybe ease the suffering, ease the overwhelm, ease the frustration. But I don't think this is a chapter of life where family members have to put the pressure on themselves that I need to be happy and joyful, and something's wrong with me if I'm not. Like, no, you have a loved one with dementia. Like, it's going to be sad sometimes. It's going to be hard to see them decline. So I think there's a lot of pressure just in society in general to, like, always feel good. And I think we need to balance that out with, it's totally normal to feel sad too. And it doesn't mean anything is wrong with you. Um, yeah.
What led you to shift from doing more clinical practice into more online um, supports?
Okay. So I had an inkling, I would say, in my mind for years. I was in Pittsburgh at the time I had it, where I wanted to do more. the thing in my mind was after diagnosing somebody with whatever dementia they had, even though I worked on a great team and we really did care for the people we were seeing, we handed them several pieces of paper with recommendations and said we would see you in a year. 6 months to a year, call us if something happens sooner. And like in my heart of hearts, I thought, oh my gosh, I know what's about to happen. I know their loved one is going to have some sort of strange behavior the family doesn't understand. I know that their family, whoever's caring, is probably going to be stretched thin, maybe not getting the best sleep. And there was just this really strong desire in me of like, how do we help them without requiring them to come into the clinic? Because I would see a lot of the family members after the fact, follow up with them. How is it going? Appointments are structured, limited. We only have a certain amount of time that we can spend with that person because we have a waiting room with other people. So no matter what, we have a hard stop. And I just started to notice it was similar people coming, similar challenges, similar struggles. They all felt alone. And I saw how incredibly hard it was for them to actually make the appointments, with them trying to keep everything afloat at the home and keep their loved ones safe. So that inkling led me to take a transfer to something from in the hospital called home-based primary care. So I still worked for the hospital, but now I was a part of a team that I went into the people's homes. The caregivers were having a hard time getting to the clinic. I'll come to you. Don't even worry about it. So I got to go into the home and either do the cognitive testing or work with the family to see like, what's the struggle? What's going on? How can I help you? And then I would just drive from home to home to home. Realistically, it's a fantastic program. However, you can really only see about 5 people a day max. You're driving all around the city, home to home to home. You can only see a handful of people. And so in my mind, that was what planted the seed of, how do I give basic education support? How do I share the common questions and struggles I see every single day with the caregivers in front of me? How do I get that out there to other people? Because not everybody's going to be a part of the VA hospital. Not everybody's going to have access to home-based primary care. So that's when I was driving a hospital vehicle, got T-boned, biggest accident I've ever been in, airbags deployed, concussion, fire ambulance came. That was what gave me the courage to say, like, just do it. Like, what am I waiting for? Life is short. So it was probably an idea in my mind 5 years. And I just thought, this is silly. This is scary. I'm a geropsychologist. I don't do things online. This whole world that exists today was not how it was back then. I got into that accident after leaving a patient's home, headed the car back to the hospital. And that was when I decided I'm going to do this. So I turned on my phone. I recorded my very first video, which was answering the most common question. And I just said, like, hey, what's the difference between Alzheimer's disease and dementia? I hear this a lot. Let me answer it. I put it out there. And in less than 24 hours, I deleted it because I'm like, this is silly. What am I doing? I don't know what I'm saying. And then maybe like it took another year for me to say, like, no, this is it. Like, I really want to help these people. I have to get over myself. I have to get over my fear and let my desire to help be bigger than my fear. So that's when I consistently, every single week, just whatever I was seeing in the clinic, whatever caregivers were talking to me about, whatever themes and questions I heard as I was doing treatment, I was like, I'm going to talk about that this week. And that's just how it started.
Wow. Is there anything specifically that you see caregivers doing to support their loved ones that are on the surface helpful? We think it's a good idea, but actually it's draining them, exhausting them, actually overwhelming them.
Yeah, I would say trying to get the person to understand they have dementia, like using the diagnosis of dementia to try to explain to their loved one, this is why you can't do this anymore. Or re- re- remember, we talked about this, like you have dementia, you can't remember. Anything that's trying to remind them that they have dementia. Sometimes the family member is doing that to just, literally remind them, hey, remember, this is why we can't do it. Um, on the surface, it sounds great, right? Because you're just trying to let them know what's going on with their healthcare and why things are the way they are. But it can lead to lots of like frustration and stress for the caregiver who keeps trying to use this explanation that's not really doing much. And it can lead to either frustration and agitation in the person with dementia who may not believe they have dementia, or if they understand they do, it might lead to a lot of sadness that this is what's happening. So I don't generally think that's a great approach. Um, I also think two other things coming to mind. One is about trying to, sometimes in our attempt to keep the person with dementia as involved as possible, which is a beautiful thing, we stop paying attention to how it's working for them. So, for example, we might have a calendar, and on that calendar, we'll say, here's your appointment here, and so's visiting on this day. And we're trying to keep them engaged, right? But for some people with dementia, it ends up adding anxiety. It ends up adding, oh, wait, is the appointment today? Let's go. And it's like, oh, no, it's on this date. Remember, here's the calendar. And they're having a hard time keeping track of the timing and the scheduling. And our attempt to keep them involved is actually adding anxiety to their life. So, one of the things I always encourage family members to think about is um, sometimes they wonder, like, am I using the right approach? And I would say, pay attention to their response. Like, we're trying to keep them engaged and involved, but they're showing you they're super anxious. Maybe the calendar is not great. You can keep the calendar on there if they're used to looking at it, but maybe we just write their favorite TV show on there. Maybe we write little smiley face or a heart somewhere. Maybe we write, um, maybe we don't put as much on there, because if it's like appointment anxiety, then we keep the appointments on a separate calendar for ourselves, and we don't even let them experience that anxiety. So that leads me into the next thing I want to say, which is it's important to think about what we're doing from their perspective and not just ours. So, for example, like from our perspective, we're thinking keeping them up to date in terms of what's happening with the schedule is wonderful. It's great. I'm keeping them involved. From the person with dementia's perspective, pay attention. Is that actually working the way that you want? Or are they showing you it's making them anxious? I'll never forget one care blazer I worked with. She recently moved her mom into a care facility, and her mom every week for you know, a decade, went to lunch. She went to her favorite restaurant for lunch. And this amazing daughter wanted to keep that tradition alive. Okay, my mom moved into this facility. I'm going to keep her tradition alive. But over time, her mom would get so like restless, agitated, anxious, headed back to the facility and even leaving the facility. At the restaurant, she seemed kind of okay, but just this travel and leaving the building and coming back into the building was creating a lot of stress for her mom. And that's where I was like, okay, but you're doing this because from your perspective, you understand everything that's happening. You understand your mom moved. She had this tradition. She liked this restaurant. She used to love going. But from your mom's perspective, if we could just like look at it from her viewpoint, she seems like she's having a really hard time with this. Like this tradition that was great before might not be great now because of how she's experiencing it all. So it's a little bit of, you know, take a moment to think about your loved one's perspective, because even though you're doing it for loving, caring, amazing reasons, your loved one doesn't necessarily know that, and that might not be their experience of it. So, uh, I think a lot of times maybe it's easy for family members to get caught in, well, what's the thing I should do? What looks nice? What looks loving? It looks loving to take your mom on this tradition that she used to have. But what is loving? Probably not giving her that anxiety and agitation and restlessness she experienced 2 times every single time you took her out of the facility and took her to this restaurant. So other people might not get it, but like you get it because you're observing your loved one and you're viewing things from their perspective. Um, yeah.
There's a question that I ask to a lot of people on this show, and I've gotten answers on both sides. So I'm curious your perspective from a board certified geropsychologist. Waterfall doors or bookshelf doors or whatever imagery we want to call it, but exits painted like a door or a waterfall, or black paint on the front of the door to keep people from going out, these sort of deterrents. What's your clinical perspective?
So when people do something like this, it is, I'm guessing, because their loved one wanders, like moves around and might go somewhere that is unsafe for them. That's where these kinds of strategies come into play. So, um, to answer your question bluntly, sure, for some people that might be fine, if it's not causing agitation or frustration. So again, we look to the person with dementia to figure out if this is the right approach for them. If they um, look and it's a wallpaper bookshelf and they don't do anything with it and they're no longer going out of the door, that could be a great response. Um, I don't see anything like majorly wrong with it, assuming we are still taking care of their need of whatever's getting them to wander, right? Like, so we have to look at what's underneath that behavior. So we're not just trying to stop a behavior from happening. I do think we need to prioritize how do we keep people safe? Like that's a big priority. But we don't want to just focus on stopping the behavior because if we do, we risk not meeting a need that would really improve their quality of life. So, for example, let's say there's somebody who likes to wander out of the house and go onto a busy highway that's in front of their home. Big safety concern, right? So the family member is going to try to do whatever they can. I'm going to put a wallpaper of a bookshelf on the door. Maybe they'll realize that's not where to go. That's fine. But now what are we doing for this person who is showing distress of some sort of wanting to leave? So are we giving them a way to exercise? Are we giving them a way to exert their energy? Are we trying to figure out, is there something they're looking for? Are they thirsty? Are they? So it's really making sure we're keeping them safe is what I picture those things to be, like the disguises. Um, Safety is good, but we cannot then ignore, is there something here my loved one is trying to communicate or the resident in this facility is trying to communicate that I still want to give attention to? Does that make sense?
Yeah.
I like to
Yeah.
I like to use the example sometimes of uh let's say somebody is agitated and walking and they're like yelling and frustrated. Well, we could jump to how do we stop them from being yelling and agitated and walking all around? Okay, well, we could jump to a medication. Okay, so now we've given them a medication that maybe sedates them, but all they were trying to do was get water because they're thirsty, but they couldn't communicate it. So now what we have is somebody who is sedated, who can't move, who is still thirsty. Like that makes me sad to think about. So I just want to make sure whenever we're coming up with an environmental strategy to stop a behavior, it's not just about stopping the behavior. It's okay, we're keeping them safe, but what else might they be trying to communicate here? Is there something else for me to learn? Is there something else that still allows them to do whatever they're trying to do or accomplish whatever they're trying to accomplish? Does that make sense?
Are, yeah, totally. Are there any common questions that caregivers ask you?
Oh, so many. Where do I start? Common questions caregivers ask me. Um, Sometimes, maybe I'm thinking just recently, is at what point do I keep going to these appointments? For my loved one. A lot of times we have a revolving door of we'll see you again in 6 months or we'll see you again in a year and we'll see you again in a year. And we'll see, especially when it comes to testing, right? Like the cognitive testing, or maybe there's like a screening of some sort. And so I just want to give all family members permission to like ask the provider, hey, what's the worst case scenario if we stop doing this? Like I, I find a lot of caregivers and people with dementia are spending their last year of life in the hospital more than at home or in the clinic more than in their facility, right? And and it's important to ask, okay, what is this appointment really going to accomplish? Because sometimes caregivers will tell me, I went to that appointment, nothing changed. We didn't do anything. We didn't like, well, why did I go? And so I do think there's a point where it's okay to ask the care provider, how necessary is this appointment? What would happen if we stopped coming? Do we really need testing again? What are we looking to get from this? Um, a lot of great people will, especially like neuropsychologists will say, we don't need to test again, you know? But sometimes what I find is there's really not a lot of treatment that we can do to help improve things. And so it seems like the one thing we can prescribe or the provider might be able to prescribe is another appointment. And so it's okay to question whether maybe those are needed or not. I get a lot of questions about stages. And so wondering, like, hey, my loved one is showing this sign right now. Does this mean they're going to a different stage? And I just want to say that we're never really looking at just one symptom when we're looking and trying to figure out stages. We have to look at the big picture. Again, this is where we want things to be super clear cut and put things in boxes. But I think any family member will tell you nothing seems clear cut. And so I think it's important to remember that people with dementia, they can sometimes have really great days, just like you and I can have really great days. And it doesn't necessarily mean their diagnosis is wrong. And people can have really bad days, or even like bad periods, and it doesn't necessarily mean they have declined to a different stage. So we really just need to look at how are they doing overall? Is there more than just this one symptom that has changed? And then a lot of times it's just watching over time. So I guess the big takeaway here that boils down to when we're talking about stages, it's really never just one symptom that's going to tell you what stage somebody's in. We've got to look at a big picture and consider multiple different variables.
And that's when you would get involved because the family may not be able to navigate that. And us having the clinical expertise in that space, we really need to rely on the experts, the credentialed folks that we talked about earlier on.
Yeah. And then some family members, I mean, they get such a wealth of knowledge and information from caring for their loved one with dementia, attending support groups, and learning from other caregivers that absolutely, talk to the healthcare team. But they'll start to get, I mean, I've met many caregivers who have way more knowledge in dementia than a lot of general practitioners who aren't specialized in dementia. So a lot of it too is just the family member taking observing, taking notes and watching what's happening over time that sometimes they'll be able to figure out like, oh yeah, I do think we're in the next stage here.
What I find interesting, Natalie, and something I've witnessed firsthand, is that a lot of the time, a lot of the clinical individuals, nurses are a good example of this. They have some level of clinical training for the home care folks. They provide this care so they can provide the clinical care. But what actually they're doing on the flip side is they're actually not caring for them personally. They're considering this is the clinical need, but they ignore the needs and specifics of this person, including, the cultural nuance. So sometimes they do things that actually cause worse behaviors on the back end because, like, clinically, this is what I need to do, but they ignore what that person needs or their cultural identity or the nuance of that culture.
Exactly. For sure. I mean, we're hiring people like for the most part, systems are hiring people for their job description, which is going to be, can I take this blood pressure? Can I pass out the medications? Can I help change somebody? But they're not hiring for the nuance of, okay, well, how would I change my approach for somebody who has dementia and I'm a stranger and they're trying to push me away. So it's like, yeah, maybe you could take the blood pressure, but can we adjust our approach and get the training and level of sophistication we need to take it for this individual? And sadly, I mean, I have worked with fantastic nurses. I think so many of them are wonderful, but also what we're asking of them with how many people to be seen, how quickly to do it in. Well, our system's not set up for them to take all this on. And we're not providing the high quality level of education to teach them how to, you know, handle a situation like that. They're in a really hard place. So yeah, I agree with what you said 100%.
I mean, the case of healthcare aides and licensed practical nurses, from what I've heard, it's like a 1 day of their entire course, which is insufficient. The
Yeah.
1 day
Yeah.
doesn't just scratch the surface on the complexity between, frontal temporal or Lewy bodies. Like,
Exactly. And a lot we kind of go through, let's let them get a training. Okay, so we checked a box. Maybe we put some new initials behind your name that you got a certificate of some sort, or you attended this training and got a continuing education of some support. Okay, but how does that really relate to, you know, what you're doing in a day-to-day in person. I think that there's probably not a caregiver who hasn't read some book, watched some video with a tip, or somebody told them what to do, and then you try to do it in your personal life and it doesn't go as planned because real life isn't a textbook. It's not a movie. It's not a video. There's so much going on that individual level that we have to adjust for and tweak. And our healthcare system cannot do that. Not only is there not the level of training, but there's just not the time or ability. Um, Too many people to see too quickly. And that's why we might have the situation of, somebody going in to offer somebody in a facility, offer somebody it's time for a shower or a bath, and the person says no, and they head out. Okay, I've got the next person to go to, right? We're not doing any sort of approach for that person.
Can you talk about or give an example of some of the impact that families have shared with you as a result of being a care blazer?
So the impact that being a caregiver has had on them?
Yes, specifically through your supports.
Yes. So I think that we get so much information from our members. They are fantastic. I love our members. They're so amazing. One of a couple of things that happens a lot is just the patience that comes, like learning patience. Like one guy comes to mind. He's like, I would have yelled. I would have been frustrated. Now I realize, like, okay, I could just let this happen and I don't have to respond. I think a theme that I hear a lot is that the care blazers in my program, their family members, so whether it's their adult kids or their friends or even their doctors, literally ask them, "What's going on with you? What changed? What's happening? You seem like a different person." So, for instance, I got an email once from a physician at a major hospital in California, and she goes, like, I just had somebody leave my office, and I had who she was when I saw her to compared to who she was when at her last appointment 6 months ago were 2 different people. I had to ask her, "What were you doing? What's going on that you're in such a, like, good headspace, motivated, feeling better?" And she mentioned your program. "Can you tell me more about what you're doing?" Or like, one Careblazer met up with some friends and they were like, "What are you doing? Why are you so different?" Like, they just notice they're happier, they're more motivated, they're less in despair, less frustration, less overwhelm. So we get lots of comments and feedback that the other people in their life have noticed a big major change. And I think that really comes down to our one of our main teachings is that we're not going to take away this dementia and we're not going to take away all of the heartbreak and pain that comes in caregiving. It comes in life. We're always going to be experiencing all that. But how do we want to respond when that happens? What kind of person do we want to be when that happens? That's where a lot of our angle comes in, because sure, we're going to help you figure out how can we reduce or prevent this behavior. Sure, we'll help you figure out maybe how to advocate for your loved one. But there's going to be another behavior. There's going to be another tweak, or the strategy that worked today might not work next week because dementia is always changing. So the one thing that we can work on that will always help us no matter what are we saying to ourselves as we deal with life's challenges? Are we saying nothing's ever going to get better? I just have to wait till this ends. What's the point? Nothing ever works. Are we saying that? Because that's going to give us a entirely different result than if we're saying, okay, I can figure something out. There's something here that I can do. I've been through hard times before. I'm going to get through hard times again. So we're not pretending this is easy, and we're not pretending this is going to be the happiest time of our life, but we are very much taking back our agency in how do I want to be right now in this stage of life, given all the realities that are happening.
So let's fast forward many, many years. If you end up getting diagnosed with dementia, what would you want the
Mhm.
experience to be like? How would you want to be cared for?
Yes. So I talk about this with my members too. I encourage them to make their dementia care plan now in terms of what they would want to have happen to them. So even simple things in terms of what music do you want to make sure people play for you? What, like for me, I have like, here's my playlist, like play some of these songs for me. Please keep bringing a dog toward, bring an animal around for me. That would be really, really helpful. Please don't ever put me on social media showing me in this state. Please, like you could create like a plan right now and share it with a loved one on how you would want to be treated. I think in the end, like in terms of like how I would want people to approach me is just knowing, just with compassion and patience, and knowing that if I am doing or saying something that is making your situation hard or miserable, I would never want to do that to you. Like I would never purposely want to do that for you. And my brain has changed in some way that it's making me do this, and I'm just sorry in advance. But like uh, patience and compassion, honestly, and don't put the pressure on yourself that you have to make me happy all the time. That's not going to be possible. Um, but if you could just like give me some great food every now and then. I always joke around like if it's possible, maybe still give me a glass of like a bourbon or a margarita every now and then would be nice and fun. Like don't take away all my pleasures. Um, and it's okay to let me go and not do all heroic measures and not try to just keep me alive to keep me alive. Um, that's gonna be personal for everybody. But I do think it's a great question for everybody listening to be thinking about what would they want their family and loved ones to know who are around them.
It's a you got to start thinking through the process now, and some of those conversations are probably pretty uncomfortable with your family because if you say this is what I want and they're uncomfortable with it, well, we need to start really diving into this piece, especially with primary directives
Yes.
and those
Yes,
sort of pieces.
absolutely.
So now we got a part called lightning round.
Okay.
All right, you ready?
Nervous for this, but let's do it.
No one's ever failed, so you'll be all right.
Okay.
Coffee or tea?
Coffee.
Morning person or night owl?
Neither. If I had to choose, I'd say morning, but I struggle to wake up and I'd like to go to bed early.
Yeah, third option. Uh, One word caregivers should stop using on themselves.
Self criticism,
One word caregivers need to hear more often.
compassion for yourself and your loved one.
What do caregivers overthink?
Whether they're doing things right.
What is the most misunderstood dementia behavior?
Denial.
What do families blame themselves for that they shouldn't?
When they make a decision and then something bad happens to their loved one, there's a negative outcome.
What is one early sign a caregiver needs to take a break?
Uh, th- Simply the desire to want to break.
Fair enough. What is one habit that quietly leads to burnout?
Isolating yourself from other people and from other supports and help.
What is one thing families are doing better than they realize?
Everything.
What is one small change that can make a day easier?
Talk to yourself like you're someone you actually care about.
What's the most human thing that's happened to you lately?
Human thing that's happened to me lately. Human thing that's happened to me lately. I totally missed trash day to put trash out, and now I have an excess of trash and I have to wait for the following week. I'm very upset with myself about that.
That's the worst. That's the worst. Um, what's one boundaries caregivers should be setting?
Um, Sticking to what you want and how you want to care, regardless of how other people think and want you to be caring, especially if they're not offering help.
What's one piece of advice you repeat because it matters?
Pay attention to how you talk to yourself and the words inside your mind. They are they're leading to your feelings and emotions. And if what I like to say is if somebody talked to you the way you are talking to yourself, would you want that person in your life? And for many people, if they answer honestly, they would realize no. And so this is a really big sign. If you would not talk to a loved one, a child, a best friend in a certain way, then you should not be talking to yourself in that certain way. Start practicing, like talking to yourself like you are somebody you actually care about and love.
Okay, finish this sentence. Good dementia care is
Specific to the person you're caring for.
what gives you hope.
People like you who people actually caring about dementia, people absolutely every single Careblazer who's sacrificing so much energy, time, attention, money to care for their loved one. People who realize that this is worth something talking about and giving attention to.
I always leave the guests as have the last word, the last opportunity to say something to the audience. This doesn't have to be one sentence. Um, so, what would you want to say to the audience?
Hmm. I would say that it's okay that things feel really hard or heartbreaking or frustrating because you literally are like facing something frustrating and heartbreaking. And um, do not try to, f- don't be upset for how you're feeling. Don't get frustrated for being frustrated. Don't be, sad on yourself that you're feeling sad. Allow those emotions to happen like waves in an ocean. Don't beat yourself up that they're happening because it keeps them around longer and it makes life so much harder. So allow your emotions without trying to push them away or ignore them or hide them. And just keep in mind every single thing you're feeling is temporary, just like the waves, right? It'll change, it'll go calm again, and it will rage again. And that's the way it has always been for all of our lives and the way it always will be. So just like kind of keeping that perspective and taking off that layer of suffering and frustration um, that you shouldn't be feeling the hard things that you're feeling.
Profound. Well, Natalie, thank you so much for joining us. It was a pleasure hearing about your experience, and I think you gave a lot of good insights and uh, tips for caregivers. So, thank you so much for joining us today.
Thank you for having me, Andrew. I appreciate it.
To our listeners, thank you for being here. If today's conversation resonated with you, make sure to follow along with the Dementia Collective wherever you get your podcasts. And don't forget to share this episode with someone who you think might benefit. And if you'd like to help us grow this movement, please consider becoming a member of the Village on Patreon. Unlimited benefits like the ability to ask questions to our guests, you'll get early access to every episode, plus the satisfaction of helping powerful voices like Dr. Edmonds reach more caregivers around the world. Finally, if you're on your own caregiving journey, remember this: you are not alone. We're here at BlueBell to help connect you with the supports and resources that truly fit your family's unique needs. Until next time, you're strong, you are not alone, and you are doing something that matters more than you know. Thank you.